Pain and temperature pathway. All the buttons in this show have been disabled for the purpose of the video. We will be looking at the pain and temperature pathway in two phases. One dealing with pain coming from the body regions and one from pain coming from the head. Following that, there will be a section on lesions of the pain and temperature pathway for the head and the body, and then some topic information related to elective surgery to relieve pain. This is an overview of the pain pathway from the body region. We have a 3-neuron pathway. The first neuron in the pathway has a cell body in the dorsal root ganglia of spinal nerves, like all other sensory information coming into the spinal cord. This enters the spinal cord, but may ascend 1 or 2 segments and then end in the dorsal gray horn. Cell bodies of neuron 2 then decussate or cross over and then become part of a pathway called the ALS, or spinal thalamic tract, which then ascends through the spinal cord, through the brainstem, and eventually ends up in the thalamus, on the nucleus and in the thalamus. Cell bodies of neuron 3 then project to the post-central gyrus. So pain sensations from the body enter the spinal cord by way of the dorsal roots. The cell body of neuron 1 is found in the dorsal root ganglia, as all sensory information coming in the spinal cord is. And once it reaches the spinal cord, it's going to ascend 1 or 2 segments. Some also even descend a little bit in what is called the dorsal lateral fasciculus, or Lesauer's tract. And then it will terminate in the dorsal gray horn, an area in the vicinity of the substantia gelatinosa. They terminate on cell bodies of neuron 2. And those cell bodies, those neurons of number 2, its axon will project and decussate and enter the contralateral anterolateral system to ascend. This is also known as the spinal thalamic tract. Neuron 2 axons continue to ascend in the spinal thalamic tract. And here we see them in the medullary level. There's also a side branch that comes off of the neuron 2 fibers to end in an area called the reticular formation. This sets up a secondary or alternative pathway for pain, which will be presented a little bit later. So axons on neuron 2 continue to ascend through the spinal thalamic tract, or ALS, and they also give off an alternative branch or a secondary branch to the reticular formation in this pontine level. And now at this midbrain level, we continue to see the ascending neuron 2 axons in the ALS, or spinal thalamic tract. Note the proximity of this tract to the medial meniscus and the BTT. That can be of clinical relevance. These neuron 2 axons do give off an alternative branch to the reticular formation, as we see here. The axons of neuron 2 in the pain temperature pathway from the body ultimately terminate in the diencephalic area in the nucleus of the thalamus, known as the ventral posterior lateral nucleus of the thalamus. The cell body of neuron 3 is in this nucleus, and its axon then projects through the posterior limb of the internal capsule and the corona radiata to the post-central gyrus. And these fibers end in a somatotopic manner, as illustrated with the stick figure on the right-hand side of this image, or left-hand side of this image. So here we see the termination sites of the pain and temperature pathway in the postcentral gyrus, somatotopically distributed. And this is where one senses first pain, a first pain event following a traumatic injury. And this pain is often described as being very sharp and well localized. Following a first pain event, there's often a period of time that we have what we call second pain. The second pain is usually described as very dull, gnawing, throbbing, very disagreeable, and can be somewhat debilitating. It is a multisynaptic pathway. It projects to the thalamus, in the nucleus in the thalamus, the intralaminar nucleus of the thalamus, and then from there it diffusely spreads throughout the cortices. And through this painful event, there's often generates very emotional or behavioral changes or responses to this pain. And that's why it can be somewhat debilitating to the patient. So here is a summary of the pain pathway for the body. It does indicate elements of the first pain pathway that gives us sharp, well-localized pain, and that is those components are components that are related to the second wave of pain, which is the dull, not well-localized, gnawing type of pain. So moving on to the pain and temperature pathway from the head region, this is an overview, and it is essentially a 3-neuron pathway. At least that's the way it's going to be described. Neuron 1, in this case, has its cell body in the semilunar ganglion, because most of the pain and temperature pathway from the head is using the trigeminal system for that. These fibers do something unusual. They enter through the sensory limb 5, and then they descend. They descend all the way down to the caudal regions of the brainstem, even into the most rostral parts of the cervical part of the spinal cord. And they synapse at that level on cell bodies of neuron 2, which then project contralaterally to the VDT on the opposite side and ascend. They ascend to the thalamus and to a nucleus in the thalamus, and on cell bodies of neuron 3 and the pathway whose axons then project to the postcentral gyrus. So the pain pathway from the head region, as I stated, is mostly related to the trigeminal system. The cell body of neuron 1 in this pathway is located in a semilunar ganglion or trigeminal ganglion. Its central axon runs through the sensory process of 5, or sensory root of 5, and then it's going to descend. It's going to descend through the spinal tract of 5. And as we'll see, it will continue on to the caudal medulla. Here in the rostral medulla, we see the pain and temperature fibers of the head region continuing to descend through the spinal tract of 5. Axons of neuron 1 in the pain and temperature pathway from the head region will continue to descend into the caudal medulla and will then synapse upon cell bodies of neuron 2 in the spinal nucleus of 5. The spinal nucleus of 5 demonstrates a somatotopy in which the 3 divisions of the trigeminal nerve are represented in a ventral dorsal relationship. So most ventrally we have the ophthalmic division of 5, and then comes the maxillary division of 5, and most dorsally we have the mandibular division of 5 represented in this complex of the spinal tract and nucleus of 5. The axon of neuron 2 projects and decussates to reach the contralateral ventral trigeminal thalamic tract. Upon doing so, it does ascend from that point. There's a second way of visualizing the somatotopic organization of pain and temperature fibers from the head region, and that is illustrated in this cartoon. This is based upon 3 onion ring type zones on the face. In each zone, all 3 divisions of the trigeminal nerve are represented. Zone 1 is called the perioral region, and the other 2, number 2 is intermediate, and number 3 is simply known as the posterior region of these zones. And you see here in the what is called the pars caudalis region of the spinal nucleus of 5, those zones are represented here. So most rostrally, we have the perioral region. Most caudally, the most posterior zone is found. So here we see axons of neuron 2 in this pain and temperature pathway from the head, continuing to ascend the ventral trigeminal thalamic tract. Note also we see the descending fibers of neuron 1 in this image. And here in the pons, we again continue to see the ascent of the axons of neuron 2 in the pain pathway from the head in the VTT. Note their close relationship to the medial lemniscus and the ALS. And continuing with the ascent of the pain fibers from the head of neuron 2, we see the VTT and the ascending axons of neuron 2. And again, note very specifically here that we have the spinothalamic tract or ALS immediately adjacent to the VTT, as well as the medial lemniscus. This is important clinically because of a lesion in this area is going to probably impact all 3 of those fiber bundles. So the pain pathway from the head, or the axons of neuron 2, will terminate in the ventral posterior medial nucleus of the thalamus, where we have the cell bodies of neuron 3. And those cell bodies will project the axons through the internal posterior limb of the internal capsule and the corona radiata to the postcentral gyrus region, where the head's represented. So here we see in the head area, where the head area is represented, the postcentral gyrus, as pointed out earlier, it's very resembling very much the fine touch pathway termination. And this is where one experiences first painful type events from the head region. We also, in the head region, can experience second pain. That alternative pathway was not pointed out to you in the pain pathway from the head, but it does exist. So one can experience second pain, certainly in the head region. So here we see a summary of the elements in the pain pathway from the head, those that are related to first pain and those related to second pain elements. So following are examples of lesions of the pain and temperature pathway. Be mostly focused on that, although the fine touch pathway may be present in some of the lesions, and that will be discussed at that time. For the most part, what we for this purpose of the lesions, when we talk about a lesion, we present it as a total loss of that sense. In the case of pain, total loss of pain is known as analgesia. Total loss of temperature is athermia. And then there is a condition that associated with these pathways that we call light touch. For the most part, if the fine touch pathway is still intact, it's very difficult to analyze whether somebody has lost light touch or not. So there'll be a color coding of the lesions that follow. If there's loss of pain and temperature only, it'll be yellow coded. If it's just fine touch deficits, it'll be just a blue in color. And if it's both pain and temperature and fine touch, it'll be green. So this first lesion we have is a lesion of dorsal roots, and we have C5 to T1. Basically, that we know that area of sensation is related to the upper limb. And then remember that the dorsal roots carry all the sensory information coming from the body are running through those dorsal roots to enter the spinal cord. So where's the area of the deficit and to what extent is it? So here we see our patient. So it is on the lesions on the left side from C5 to T1. We would expect the lesion deficits to be on the left side or ipsilateral. And it would include not only pain and temperature, but also fine touch, because all the sensory information coming in through C5 to T1 is cut off. So it'd be ipsilateral loss of pain and temperature and fine touch, and the deficits associated with that. Analgesia, anesthesia, etc., etc. This condition is called cavitation of the central canal of the spinal cord. Specifically, it's called syringomyelia, and that starts out as a small cavitation, and it can eventually expand into a much greater area. Initially, this is what one experience, and what would be the impact of that. So with this cavitation or syringomyelia of the central canal, you have to see what fibers are involved, and it's mainly fibers of neuron 2 in the pain pathway that are crossing over in the anterior white commissure. By affecting those fibers, you're going to have loss of pain bilaterally. The range of this lesion is C of LL3 to L5. The primary dermatoma that's going to be involved in the loss of pain will be approximately L4, as illustrated here. So here's a lesion that involves the anterior fediculus, lateral fediculus, ventral gray horn. So the deficits in this patient would be more extensive than just pain and temperature, but we're going to focus just on the pain and temperature, as we'll see on the next slide. And this could be due to an occlusion of the anterior spinal artery. So here's our lesion, and the area where it is found certainly impacts the anterior lateral system, or the spinothalamic tract, on the left side. That particular spinothalamic tract is receiving axons of neuron 2 that have decussated and started to ascend. And anything below C4 would be probably coming up through that spinothalamic tract on the left side. The deficits, because it has already crossed over, would be on the contralateral side of the body, because the spinothalamic tract represents crossed fibers. So the area would be fairly extensive in this patient, maybe starting about C5 or 6, where the loss of pain is going to be prominent, and it should be on the contralateral side of the body. So here we see it on the right side, and covers, as I said, much of that right side of the body, upper limb, lower limb, trunk. And it's really just related to the loss of pain sensation. In this, adjacent to the spinothalamic tract, there are descending hypothalamic fibers So with such a lesion, there's often some autonomic nervous system deficits because of descending hypothalamic axons. One thing that may show up is a ipsilateral Horner syndrome in a patient with such a lesion. So here we have a section of the brainstem, and what level would you call this? Well, based upon the features, it should be open medulla with the inferior olivary nuclei present, the pyramids present, the fourth ventricle present. So the area of the lesion is this lateral medullary area. This lateral medullary lesion does involve two pain pathways. The spinal tract of 5, carrying descending pain fibers from the head, and the ALS carrying ascending pain fibers from the body. The pain fibers from the head are coming from an ipsilateral side, so we expect to see ipsilateral deficits. Those in the ALS from the contralateral side, and so obviously contralateral deficits. So the area distribution of the analgesia we'll see on the right side from the body, because the lesion was the ALS on the left, and the head will be on the left side because of the left-sided lesion of the spinothalamic tract. This is known as alternating analgesia. So our next lesion is in this brainstem region. What level is this? Well, it is the rostral midbrain, and we call it the midbrain because we have two prominent bundles ventrally, the crus cerebri. We have some gray matter just dorsal to that, the substantia nigra, and then there's also a small opening in the central region dorsally, and that's the cerebral aqueduct, all features of the midbrain. Now, rostral midbrain does have a fairly large nucleus called the red nucleus or red nuclei because it's bilateral, and there are also fibers coming from an oculomotor nucleus, and these are the third cranial nerve fibers or oculomotor nerve fibers exiting in the interpeduncular fossa. So what is involved in this lateral midbrain lesion? Well, now we see within that lesion, we see the spinothalamic tract, the ventral trigeminal thalamic tract, and part of the medial lemniscus. Those are all carrying crossed fibers that have decussated. So all of the deficits should be on the contralateral side. The only thing we have to discuss here, what about the medial lemniscus? Not all the medial lemniscus. So we know those fibers are somatotopically organized, and at this midbrain level, the most dorsal part of the medial lemniscus carry the lower limb fibers. So we're going to have both loss of pain and temperature in this case, and let's look at the distribution of the pain and temperature. So there's loss of pain throughout the body, and there's loss of fine touch in the lower trunk and limb lesion because of the portion of the medial lemniscus that is involved, and it's on the contralateral side of the lesion, which would be the left side. And as far as pain of the head region, that's on the left side because we've involved the VDT. Loss of pain, I should say. There are also some descending hypothalamic fibers in the vicinity of the spinothalamic tract, so that this could result in a patient having some autonomic deficits because of those fibers being lesioned. The following is a case where we have a 38-year-old female patient who developed diplopia, or double vision, and unpleasant tingling on the right side of the face. On physical exam, the patient had pain, temperature, and fine touch sensations diminished on the right side of the face, mostly in the vicinity of the maxillary and mandibular divisions of the face. The diplopia was determined to be due to a lesion of the right trochlear nerve. The right trochlear nerve innervates the superior oblique muscle of the eye. 1 month later, the sensory deficits normalized, but the double vision persisted, mainly when looking downward. We're looking at an axial MRI of the head, focusing on the area where the arrow is. We're looking at the midbrain, and of course the midbrain is, we have the ventral aspect of the midbrain facing upward and the dorsal aspect facing downward. You can see the cerebral aqueduct there in the midbrain. We can see the area of the crus cerebri of the midbrain very, very well. And you have that low signal intense area. That's an area where there's a vascular infarct. And you have to think of what structures are in that vicinity. So I've recreated this lesion, this infarct on this section of the midbrain, so that we can see what structures have been impacted. The trochlear nerve is in the path of that lesion. The trochlear nerve does sweep dorsally. It's the only nerve that runs and exits the dorsal aspect of the midbrain. And those fibers do decussate, so that it becomes the right trochlear nerve, which innervates the right superior oblique muscle, the reason for diplopia. It also is impacting the VTT, which is carrying pain and temperature information from the contralateral side of the head, where we would have deficits associated with that on the right side. So this is a further observation of this patient who had this lesion in the midbrain. Since the VTT carries both pain and temperature and fine touch from the head, we would see diminished sensations of those two sensibilities in the head region, both pain and temperature and fine touch. So we have another brainstem level. On what level would this be? Should have thought or answered caudal pons. And the area of the lesion is the lateral pontine lesion. This lesion impacts two pain pathways: the spinal tract of 5, carrying fibers from the ipsilateral, pain fibers from the ipsilateral head, and the spinothalamic tract, or ALS, carrying pain fibers from the contralateral side of the body. The consequence of this is a classic condition of alternating analgesia, where we have ipsilateral loss of pain in the head and contralateral loss of pain on the body. So what are the primary structures that are enclosed at the site of the lesion? Well, they are the posterior limb of the internal capsule and the thalamus. Because the lesion involves the thalamus, where we have nuclei associated with the fine touch and the pain and temperature pathways, and also involves the internal capsule, also carrying information from those nuclei in the thalamus to the cerebral cortex, we would expect to see loss of pain and temperature in both the head and body regions. It would all be on the contralateral side, because those pathways at this point have already crossed over. So here we see deficits on the right side of the body, since the lesion was on the left. This particular lesion would be more extensive as far as what it would involve, because there are elements of the motor pathways that are affected here too, but We're just really dealing with sensory pathways at this point. Sometimes the only way to give a patient relief from the pain they're experiencing is to have some elective surgery. And the following are 3 procedures that are sometimes used. The 3 surgical procedures that can be used are rhizotomy, chordotomy, and tractotomy, which we'll review in the following slides. Rhizotomy is a procedure of selectively lesioning dorsal roots from a region of severe pain or gnawing pain, any kind of pain. And because of that lesion, the patient would lose all sensation from those dermatomes involved, not just pain sensation. Chordotomy is a process of putting a microelectrode surgically into the ALS. The ALS is fairly close to the surface of the interlateral portion of the spinal cord, and a neurosurgeon can be very selective as to where that electrode is being placed. If it's more dorsal lateral, that is a region of the lower limb representation, and more ventral medial will be upper limb, because of the somatotopic organization of fibers. Tractotomy involves a selective lesioning of the fibers of the spinal tract of 5 before they reach the spinal nucleus of 5 in order to alleviate pain in selected areas of the head region. This can be done because of the somatotopic arrangement of these fibers that was covered in the various aspects of the slideshow.